Now let's talk about cholinomimetic drugs or cholinergic drugs. These are the drugs which have acetylcholine-like effects. They are further classified into two groups on the basis of their mode of action, whether they act directly or indirectly. So among the direct ones, we have nicotinic and muscarinic ones. For the muscarinic cholinomimetic drugs, please remember choline esters, for example acetylcholine, and alkaloids, for example pilocarpine. Now let's talk about the indirectly acting cholinomimetic or cholinergic drugs. For this, please remember ECO, E for edrophonium, C for carbamates, and O for organophosphates. Please remember that edrophonium is short-acting, carbamates are intermediate to long-acting, for example neostigmine. Organophosphates are very long-acting, for example parathion. Okay, now let's talk about muscarinic agonists. They are parasympathomimetics, that means mimic the action of parasympathetic nerve stimulation in addition to other effects. Now we can classify muscarinic receptors into 5 subgroups, and muscarinic agonists are also available. Okay, now let's talk about direct acting cholinomimetic agonists. This group consists of choline esters as well as alkaloids. For the choline esters, we have MACB. Please remember MACB from Macbeth. So for M we have methacholine, and then for A we have acetylcholine, for C we have carbachol, and for B we have bethanychol. And then we have a second group which consists of alkaloids. For that, please remember NP and L, which means M for muscarine, pilocarpine, N for nicotine, and L for lobeline. Drugs are also introduced for special applications, for example neonicotinoids, clothianidine, imidacloprid, and other insecticides, but they have been banned because of their adverse effects, and they differ in their mode of action. And if we talk about nicotinic agonists, then they act both on ganglionic as well as neuromuscular cholinereceptors. Agonist selectivity is limited. For the nicotinics, the agonist selectivity is limited. On the other hand, slightly selective muscarinic antagonists and more selective nicotinic receptor antagonists are also available. Okay, now let's talk about the terms that will be commonly used. For example, first of all, we have choline ester. It is basically a choline which is bounded with an ester, for example, an acid like carbamic acid or acetic acid. Now let's talk about cholinergic crisis, and then we'll talk about myasthenic crisis. So in cholinergic crisis, what happens is that there is worsening of conditions. For example, there is excessive activation of the cholinereceptors. So as a result of that, there is weakness of the skeletal muscles as well as parasympathetic effects. This is due to the excessive activation of the cholinereceptors, and it is caused by cholinesterase inhibitors. Symptoms are closely related to the symptoms of myasthenia gravis crisis. Now let's talk about myasthenia crisis. In patients with myasthenia, there is acute worsening of the symptoms, which are usually relieved by increasing the cholinesterase inhibitor treatment of cholinergic crisis. How to differentiate between cholinergic crisis and myasthenia crisis? Cholinergic crisis is due to the overstimulation of the cholinergic receptors or due to excessive cholinesterase inhibitors, while myasthenia crisis is basically just worsening of the symptoms of myasthenia gravis. And if we talk about cholinergic crisis, then cholinergic crisis can be worsened with a small dose of tensilon or edrophonium, and the symptoms of cholinergic crisis include muscle fasciculation. But if we talk about myasthenia crisis, then myasthenia crisis is going to improve with a small dose of edrophonium and tensilon, and the symptoms will not include muscle fasciculations. Now let's talk about cholinomimetic alkaloids. So basically, they are drugs with alkaline properties that resemble those of acetylcholine, usually lipid soluble. Now let's talk about cyclospasm, a large contraction of the ciliary muscles for maximum accommodation for the close vision. Now let's talk about direct acting cholinomimetics, which directly activate the cholinereceptors. The effects mimic those of the acetylcholine. Now for the EDRF, please remember the vasodilator nitric oxide. For the indirectly acting cholinomimetics, we have, as I told you before, we have these 3 groups. So they amplify the effect of endogenous acetylcholine by inhibition of acetylcholine esterase. Talk about muscarinic agonists. Then these are cholinomimetic drugs that bind with the muscarinic receptors and have muscarine-like actions. Now let's talk about neonicotinoids. They're a class of insecticides with nicotine-like properties, and they act on neurons. If we talk about nicotinic agonists, then they are cholinomimetic drugs that bind with nicotinic receptors. They have primarily nicotine-like actions. If we talk about organophosphates, then they consist of phosphoric acid and an alcohol that inhibits the choline ester, and they are bound with ester bond. If we talk about organophosphate aging, then it is a process where the organophosphate, after binding to choline esterase, is chemically modified and it becomes more firmly bound to the enzyme. And these are basically cholinergic drugs, which resemble those of stimulating the parasympathetic nerves. Okay, now let's talk about some cholinomimetics, their spectrum of action and their pharmacokinetics. For that, I have an mnemonic for you, which is ABCPNNV. Okay, so please remember ABC separately, and then remember PN, and then remember NB. Okay, so now let's talk about ABC. A is for acetylcholine, B is for bethanyl, C is for carbachol. Also for their spectrum of action, please remember BM, and NN. For the acetylcholine, please remember that it is rapidly hydrolyzed by choline esterase. Its duration of action is 5 to 30 seconds, and it is poorly lipid soluble. Now, when we talk about bethanyl and carbachol, they have the same pharmacokinetic features, and please remember that they are resistant to choline esterase, unlike acetylcholine, which is rapidly hydrolyzed by choline esterase. They are resistant to choline ester, and they have poor lipid solubility, just like acetylcholine, and their duration of action is a little different, because for acetylcholine the duration of action was 5 to 30 seconds, but for bethanyl and carbachol duration of action is 30 minutes to 2 hours. And also bethanyl and carbachol are orally active. Now let's talk about pilocarpine. So pilocarpine is not an ester, and nicotine is not an ester. Both of them are nicely lipid soluble. When we talk about pilocarpine, it has good lipid solubility, but when we talk about nicotine, it has high lipid solubility. So now let's talk about the duration of action of pilocarpine. It is the same as the ABCs, which is 30 minutes to 2 hours, but when we talk about nicotine, duration of action is 1 to 6 hours. Now let's talk about neonicotinoids, which were used as insecticides. And then we have varenicline. So for varenicline, please remember that it is a partial agonist at N receptors, and it has high lipid solubility, and the duration of action is half day to 1 day, which is 12 hours to 24 hours. Okay, now let's talk about the indirectly acting cholinomimetics. So first of all, we have edrophonium. Edrophonium is an alcohol, and the duration of action is just 5 to 15 minutes, so it is short acting, and it is not orally active, and it is poorly lipid soluble, and it is also a quaternary amine. Now let's talk about neostigmine, physostigmine, and pyridostigmine. All of them are carbamates. Now if we talk about neostigmine and pyridostigmine, their mode of action is similar, because they are both carbamates and they are both quaternary amines with poor lipid solubility, and both of them are orally active, but the duration of action is going to be different, because for neostigmine the duration of action is 30 minutes to 2 hours or more, but for pyridostigmine the duration of action is longer, which is not just 30 minutes to 2 hours, but it is 4 to 8 hours for pyridostigmine. Now if we talk about physostigmine, it is a tertiary amine, so it has good lipid solubility, because for quaternary amines the lipid solubility is going to be poor, but for tertiary amines, for example physostigmine, it has good lipid solubility, it is going to be orally active, and the duration of action is 30 minutes to 2 hours. So edrophonium duration of action was 5 to 15 minutes, which was short acting. For neostigmine and physostigmine, duration of action was 30 minutes to 2 hours, but for pyridostigmine duration of action was the longest, which was 4 to 8 hours. Now let's talk about the organophosphates. These we have 3 examples, which are ecothiopate, parathione, and sarin. Ecothiopate has moderate lipid solubility, parathione has high lipid solubility, and sarin has very high lipid solubility, because it is a nerve gas. So now let's talk about ecothiopate in detail. Duration of action is going to be 2 to 7 days, and then for parathione the duration of action is going to be 7 to 30 days, and it is an insecticide. Okay, now let's talk about cholinereceptor types and their post-receptor mechanisms. So please remember that we have M1, 2, 3, 4, 5 receptor types, and then we have NM and NN. Now let's talk about the M1 type. So please remember that the post-receptor mechanisms are going to be very easy to remember, because M1 is going to increase IP3 and diacylglycerol cascade is going to be activated, and M2 is going to decrease cyclic AMP synthesis, M3 is going to increase the IP3 and diacylglycerol cascade, M4 is going to decrease the cyclic AMP synthesis, and M5 is going to increase IP3 and diacylglycerol cascade is going to be activated. But when we talk about nicotinics, NM and NN, they're both going to activate the sodium or potassium depolarizing currents, and they do not have any G proteins. But for M1, 2, 3, 4, 5, the G proteins are going to be GQ, GI, GQ, GI, and then GQ. Okay, now let's talk about the muscarinic mechanisms. So as you know that M1, M3, and M5 share a similar mechanism of IP3 and diacylglycerol cascade. So let's talk about them in detail. Protein is going to attach the receptors to phospholipase C, which is a membrane-bound enzyme which leads to the release of second messengers, which are diacylglycerol, and IP3, which are inositol 1,4,5 triphosphate. Diacylglycerol is going to regulate the action of protein kinase C, which is an enzyme important in secretion, whereas IP3 or inositol 1,4,5 triphosphate is going to evoke the release of calcium from intracellular storage sites, which in smooth muscles is going to result in contraction. Now let's talk about the mechanism of M2 and M4 muscarinic receptors, which is going to use the GI protein. So muscarinic receptors are going to couple to the adenylyl cyclase through the GI coupling protein. So a third mechanism for the M2 receptors is through the beta-gamma subunit of the G protein to facilitate the opening of the potassium channels in the heart and elsewhere. Also, please remember that M1, 2, 3, 4, 5 are present in different organs. For example, please remember the mnemonic of Nadia have effector CNS for this. So for M1 we have nerve endings, for M2 we have heart, and for M3 we have effector cells including the smooth muscles, the glands, and the endothelium. And then for the M4 and M5 we have CNS. And then we have for the NM and NN, we have NM we have nerve ganglion, and for NN we have neuromuscular junctions. Okay, so M4 receptors are present in the CNS. They play an important role in the basal ganglia, regulating the dopamine's action in the initiation of movement. However, M5 receptors are present in the CNS as well. They play important roles in the dopaminergic projection neurons of the CNS. M4 and M5 are found. They are found sparingly on the enteric neurons, but they have not been able to show major roles in the peripheral organs. Now let's talk about nicotinic mechanism. They are basically through the sodium or potassium depolarizing currents. So these are transmembrane channel proteins which are made up of 5 subunits. Okay, so now let's talk about the nicotinic acetylcholine binding site, which is going to be present between the alpha subunit and some of the other subunits, depending on the nicotinic protein structure. The nicotinic channel protein is selective for sodium and potassium. So you guessed it right. When the receptor is activated, the channel will open, and depolarizing will result in the influx of sodium, which will cause an EPSP, which is an excitatory postsynaptic potential. If large enough, the EPSP will evoke a propagated action potential in the surrounding membrane. The nicotinic receptors on parasympathetic and sympathetic ganglions as well as in the CNS. NN is for ganglion or NG. They will differ slightly from those on the neuromuscular end plates. NM. Okay, so now let's talk about the tissues and organ effects. So let's talk about vasodilation. So please remember that vasodilation is not a sympathomimetic response, but it is mainly evoked by the EDRF or the endothelial-derived relaxin factor, mainly nitric oxide, mediated by uninnervated muscarinic receptors on the endothelial cells. Also, due to the decrease in the blood pressure, we are also going to notice the baroreceptor reflex, resulting in strong compensatory sympathetic discharge to the heart. As a result, injection of small to moderate amounts of directly acting muscarinic cholinomimetics is going to cause tachycardia, whereas in the case of parasympathetic or vagal nerve discharge, this is going to result in bradycardia. Now, we're also going to notice sweating in case of sympathetic response with the sympathetic cholinergic effect, but sweating is not going to be present in cholinomimetic drugs. Now, blood vessels are going to be dominated mostly by the sympathetic innervation. Therefore, nicotinic receptor activation in the ganglia results in vasoconstriction mediated by sympathetic postganglionic noradrenergic nerve discharge. Now, if we talk about the gut, it is dominated by the PNS. So nicotinic drugs will increase the motility and secretion because of increase in the neuronal discharge. Nicotinic neuromuscular end plate activation by directly acting drugs results in fasciculation and spasm of the muscles involved. Prolonged activation results in paralysis, which is an important hazard of exposure to nicotine-containing and organophosphate insecticides. Now let's talk about the clinical use of parasympathomimetics. So there are several clinical conditions which benefit from an increase in the cholinergic activity, including glaucoma, Sjogren's syndrome. So please remember J for that. And also when there is loss of normal cholinergic activity in the bowel and the bladder. Also, directly acting nicotinic agonists are used to assist smoking cessation, as in the case of varenicline, and also to produce skeletal muscle paralysis in the case of succinylcholine. Now, if we talk about indirectly acting agents, so they are used when increase in the nicotinic activation is needed at the neuromuscular junction, when in the case of myasthenia gravis. Nicotine and related neonicotinoids are used as insecticides despite reported toxic effects on the bee colonies. Varenicline is a nicotinic partial agonist, and it appears to reduce craving in persons which are addicted to smoking by causing smaller amounts of dopamine released as compared to nicotine itself. Let's talk about the effect of cholinomimetics on the major organ systems. So first of all, let's talk about the CNS, which has both muscarinic as well as nicotinic effects. So please remember nicotine and then remember 5-stigmine for that. So what is nicotine going to do? It is going to cause mood elevation and alerting of the mood as well as addiction. Nicotine naive individuals are also going to suffer from nausea and vomiting on initial exposure. However, in large dose, this can also result in seizures. But when we talk about physostigmine, this can result in convulsions and coma. And now let's talk about eye. So first of all, we have the sphincter muscles of the eye, which are going to contract as in meiosis. And then we have the ciliary muscles of the eye. So the ciliary muscles of the eye are going to contract, which is going to lead to cyclospasm. Now let's talk about the heart. So for the sinoatrial node, and then atria, and then AV node and ventricles. So there is going to be negative chronotropy, negative inotropy, and then negative dromotropy. So please remember CID for that. So chronotropy means decrease in rate, inotropy means decrease in contractility, and dromotropy means decrease in the velocity or conduction velocity. And for the ventricles, there is going to be a small decrease in the contractile force. And the blood vessels are going to dilate, and the bronchi are going to constrict. And for the GIT, we have motility and sphincters. So motility is going to increase because there is going to be increase in the peristalsis. But for the sphincters are going to relax except for the GE sphincter. And then let's talk about the detrusor and trigone and sphincter of the bladder. So detrusor is going to increase in contraction. Trigone and sphincter is going to relax. And the skeletal muscles are going to be contracted due to activation of NMJ end plates, neuromuscular end plates. And for the glands, they are going to increase in secretion, including thermoregulatory sweating, lacrimation, salivation, bronchial secretion, GIT, gland secretion. Now let's talk about muscarine toxicity. These effects include increase in the CNS stimulation and also the meiosis and the cyclospasm of the eye. And for the heart, it can be transient bradycardia, which occurs followed by reflex tachycardia if the drug is administered as IV, or reflex tachycardia otherwise. And muscarine and simultaneous alkaloids are also found in certain mushrooms like Inocybe species and also Amanita muscaria, which are responsible for short duration type of mushroom poisoning, which is characterized by nausea, vomiting, and diarrhea. But the more dangerous mushroom is Amanita phalloides, which is involved in causing vomiting and diarrhea as a short duration, but afterwards it is followed by hepatic and renal necrosis. It is not caused by muscarinic agonists, but it is caused by amanitin and phalloidin, which are RNA polymerase inhibitors. Now, nicotinic toxicity. So they include ganglionic stimulation and blockage and neuromuscular end plate depolarization, leading to fasciculation, then paralysis, fasciculation, spasm, and paralysis. CNS toxicity and includes stimulation, including convulsions followed by depression. Nicotine in small doses, that is through smoking, is very addicting. In the case of vaping in the US, it has become a relatively common method of inhalation of nicotine. A solution of nicotine and flavor additives is placed in a special cigarette holder and vaporized by an electric heater in the holder before it is being inhaled. CNS effects are the same as those experienced by tobacco smoke. When we talk about the indirectly acting agonists, so they can be classified into two major chemical classes, which include carbamic acid esters like carbamates and also phosphoric acid esters like organophosphates. All of them are basically acetylcholinesterase inhibitors. If we talk about neostigmine, then it is a prototypic carbamate, whereas parathianoate is going to be a prototypic organophosphate. It is an important insecticide. Then there is a third class which is made up of alcohol, which is basically hydrophonium. It is an alcohol, not an ester. It has a very short duration of action. Now let's talk about the mechanism of action. Okay, so both of the carbamates and organophosphates inhibitors are going to bind to the cholinesterase and they are going to undergo hydrolysis. Now the alcohol portion is going to be released in a short duration and the acidic portion is going to be released more slowly from the enzyme active site. This prevents the binding and hydrolysis of endogenous acetylcholine. As a result, these drugs are going to amplify the acetylcholine effects wherever the transmitter is released. Now, when we talk about hydrophonium, it is not an ester, but it has sufficient affinity for the enzyme active site to similarly prevent the access of acetylcholine for 5 to 15 minutes. And then after hydrolysis, carbamates are released over a period of 2 to 8 hours maximum, and organophosphates are much longer acting. They form an extremely stable phosphate complex with the enzyme. After hydrolysis, the phosphoric acid residue is going to release over a period of days to weeks. Recovery is due in part to synthesis of the new enzyme. Now let's talk about the effects of the indirectly acting cholinomimetics. So by inhibition of cholinesterase, these agents are going to cause an increase in concentration, half-life, and actions of the acetylcholine in synapses where acetylcholine is physiologically released. However, at the places where there is no innervation of the acetylcholine, the cholinesterase inhibitors do not have significant actions. For example, in the vascular endothelial cells, they do not have significant actions. Therefore, the indirect agents have both muscarinic and nicotinic effects. Dominant effect varies among the organ systems.